2 years of the pandemic, we have become familiar with many new concepts. Flattening the curve, social distancing, mRNA vaccines, N95 masks, and even several letters of the Greek alphabet. The only constant seems to be that we are continually learning to cope with life during COVID. Joining us today is Dr. Ajay Kumar, Chief Clinical Officer, and Keith Grant, Senior Systems Director for Hartford Healthcare, to discuss where we are and where we are likely to go. We'd like to thank our premier sponsor, Digital Back Office Palo Alto Networks. Check them out at digitalbackoffice.com or paloaltonetworks.com. The Municipal Voice is the Connecticut Conference of Municipalities podcast in collaboration with NHH LP 103.5 FM. I'm your host, Matt Ford. As always, be sure to give us a like and let us know what you're thinking in the comments. CCM's Municipal Voice podcast continues to present a key forum on important state-local issues. The views expressed do not necessarily reflect the consensus views of CCM or member municipal leaders.
Dr. Kumar, Keith, thanks for joining us today.
Absolutely. Thanks for having us.
Yeah, it's good to have you here. So you both work at Hartford Healthcare. Can you tell us a little bit about what you do individually and how that specifically relates to your expertise and your general knowledge of viruses and public health?
Keith, why don't you go ahead?
Yeah, absolutely. So I'm the Senior System Director for Infection Prevention at Hartford Healthcare, also a practicing clinician as an APRN in the Infectious Diseases Department, where I get to work very closely, not just with infectious diseases, but working in epidemiology with Dr. Ulysses Wu. In regards to credentialed, and I think no one's been credentialed to manage COVID-19, to be honest with you. And we found that there's a lot we had to learn. But one of the things that we've said is we've had professionals that's been positioned to manage emerging infectious diseases. And we're lucky enough that we have some great experts in our team, such as, the Ulysses Wu, positioned through the leadership of Dr. Kumar. I would say that, working within epidemiology, one of the things that we get to do is we get to monitor emerging infectious diseases around the world. So we get to appreciate an endemic state, define what that is, and appreciate what is a true pandemic, and define and manage what that is, from anything from HAIs, hospital-acquired infection, to flu influenza season, to the efficacy of the flu vaccine, to now we have COVID-19, and we went through Zika, we went through Ebola, and so forth.
So COVID's kind of the big one right now, obviously, but you've
absolutely
been at this on other diseases, and you will continue to be at this in the future as, unfortunately, these diseases pop up.
Yeah, it's an intellectual journey that you have to be willing to adapt to, you know what I mean? And we've been able to learn a lot from COVID-19. I started this by saying no one really could be prepared for this. But in theory, like we've talked about this in a lot, over the last, I'd say 5 to 10 years, we've talked about where we've seen viruses, mutations that are happening and where the expectation is from a predictive analytics perspective. But as I said before, it is a constant intellectual journey, and we continue to learn and we continue to build in order to protect our colleagues and our community.
Excellent. Doctor?
Matt, I'm a Chief Clinical Officer for Hartford Healthcare. Essentially, my responsibilities are quality and safety across the system. Hartford Healthcare is a large system with 7 hospitals and primary care network, behavioral health network, community network, and obviously my role is to create standards and practices which are consistent with appropriate policies, but at the same time with the eyes towards safety across the system. In summary, that's my role, but there's other hats I wear, but this is one of my primary role right now in the pandemic.
That's the short version. I'm sure there's a lot more to it. So on the show, we had one of the local health district's public health directors on the show in March of 2020. And, then it was like we were going to bump elbows, but we didn't have masks on. We were sitting at the same desk. And we didn't know at that point this was going to kind of become, unfortunately, a yearly episode for us. Thinking back in those early days of the pandemic, is there things that we missed, or was just impossible to tell how this was all going to pan out? Keith looks like he has something to say on that one.
Keith will always take the first shot on the questions.
Yeah, I don't know if I don't know if we would, I don't know if I'm gonna accept that we missed something. I think, you know, one of the things in Ulysses, and I quote him a lot, and you probably will quote him a lot in this statement. So Dr. Wu says in the beginning of this, viruses do what viruses does, right? And one of the elements that weren't available about 12 months ago was the variations and the mutations that we saw within this virus. We saw the Delta variant, and we're now seeing the Omicron variant as well. So that's one factor. The other piece of it is factor in the true impact of the COVID-19 vaccine. We've seen a significant impact in many ways, that it's helped to reduce cases, deaths, clinical impact, and so forth. But it's also provided somewhat of a comfort to our community, and that might in turn have impacted how we responded by ensuring that masking and so forth continue, right? Which is not necessarily a horrible thing, because people are trying to get back to normal as possible. So I think there's a multitude of variables that I'm sure we'll get into some of those variables during the show, but there's a lot of variables that there's no way we could see. And what it did though, it's created somewhat of an appreciation for what we need to look at going forward and continue to look at going forward.
Yeah, it's interesting. I think, you know, with what you do, obviously it's a medical field, but there is a lot of like sociology and just understanding how people think and react to things that goes into that sort of
absolutely
those calculations. Absolutely. Doctor?
Matt, I agree with Keith. I think we understood more about the virus than the people in this pandemic. And I think the challenge has been that how do we consistently pass a message, understand the sentiment of the public, and make sure that our communities respond to the way it needs to be. You know, in saying all that, in a microcosm of Connecticut, I think Keith will probably agree with me that we are very proud of Connecticut, how our state has responded, how our communities have responded, with a high vaccination rate and reasonable understanding of the PPE and the masking guidelines. And there's so much to be proud of being part of Connecticut. In the larger world, I think we're a bit more challenged. We are challenged by different states and different countries, how the behavior has been, or the lack of acceptance of the vaccine, the distribution of vaccines. Pandemic is a global problem. It's not just a Connecticut problem. But I think we've done very well as we could have done in Connecticut in itself.
Yeah, I know at various points throughout this, Connecticut has been, you know, number 1 or 2 for top safety. Yeah. Obviously, right now we're experiencing a surge like everybody else, which I guess shows that even people that are doing the best at it can still do better, and that it's still going to be something we have to watch for. Keith, you mentioned a little bit about the variants before, but can you explain the difference between Alpha, Delta, Omicron, and why these differences matter? Like, why should people care?
Yeah, so, you know, we've gone through a number of variants of a concern is the ones that we've designated titles, such as Alpha. Alpha variant B117 came about November of 2020 is when we started seeing this. A variant that is believed to have some level of mutations, but is about, at that point, was about 30 to 50 times more contagious than the original SARS-CoV-2 variant. Quickly sunset by the Beta variant, which was the B1351 that was discovered in South Africa. And again, a variant that is even more contagious, identified at about 50 to 60 times more contagious, more likely to lead to hospitalizations, and more likely to lead to death. Additionally, with the Beta variant, what we saw and started communicating was whether or not this variant had the potential to evade antibodies and possibly evade detection through technologies such as PCR. Soon after, we had the Delta variant, and Delta variant was probably one of the first variants that created a platform of significant, being overly contagious beyond what we would imagine the Beta variant had to offer. Identified B16172 was about 80 to 90% more contagious, not than the original variant, but then the Alpha variant, which remember was identified as even significantly more contagious. And that variant itself, again, one of the Delta variant has been around for a good number of months. If you think about the transition of all the other variants, the Delta variant is really the one who's really survived, right?
Yeah.
And the questions with the Delta variant that we were very concerned with is whether or not this variant was evading or antibodies to include or vaccinations. And then we had the Omicron variant. The Omicron variant, I think for us, the thing that was most concerning is one, this was a variant that seemed to be significantly contagious. I mean, in South Africa, numbers went from new cases from 300 to 3,000 in a matter of days in certain areas. So we appreciated a significantly more contagious variant. We also saw something that was slightly different. We saw a number of patients that were positive were individuals that have been vaccinated, and even younger individuals as well. Very concerning. Is it evading our actual antibodies that are being created by or vaccine? Additionally, there's the mutations eclipse what we saw before. So we saw about over 50 mutations, of which over 30 were specifically on the spike protein. And that's important because the spike protein is our identifier from a phenotype perspective. So when we look at this virus, the thing that we attack and we use for detection, and the thing that we target with our antibodies from the vaccine itself, is the spike protein. So the biggest concern in the scientific community was, if this targeting body is now having the majority of mutations, then should we be concerned about our antibodies? Should we be concerned about our detection protocols and so forth? Luckily, so far, we've had good efficacy from our vaccines, good efficacy from preceding antibodies and so forth. And we continue to monitor, CDC, WHO, Hartford Healthcare, working with Jack's lab, Yale, and other health systems are working to do genomic sequencing. So we're continuing to keep an eye on if there's any more mutations or any more variants coming out. But as it stands right now, the Omicron variant is the predominant variant in the state of Connecticut, we believe, in the country at this point. I don't think we have enough data to conclude if its impact clinically, but the preliminary data that we do have is that the impact seemed to be lessened, but it is seemed to be significantly more contagious than all other variants that's been before.
Wow, that's pretty wild. So where you're seeing the mutations, it's specifically in the part where it's trying to figure out ways to get around our antibodies. That's frightening.
Yes, and that's giving it a lot of credit, and you might be right. And one of the things, the aim for a virus is for it to survive as much as possible. I was recently reading it's a spin on science that is not as scientific. And one of the things that they said was, the variant is probably trying to figure out, listen, if I keep my host alive and I'm more contagious, I'm able to spread more, right?
Yeah,
and
the common cold, the flu have been around forever and ever because they've figured out that kind of point where they don't take everybody out, but they can spread. Yeah.
So that might be the conversation that that COVID-19 had with influenza, and they decide this is probably the best direction to go in. But this is currently where we are with COVID-19 from a variant perspective.
Yeah, and as you said, the big kind of scary ones get name, and we talk about Omicron, but there's more than Alpha, Beta, Delta. There's 50 or whatever you said that have been identified.
Hundreds to thousands of variants so far for COVID-19.
Doctor, we've heard that the more people that get the virus, the more chances that the virus has to mutate into a new variant. How common is this? And as we know with Omicron, it doesn't necessarily always mean worse, but should we be concerned about all these mutations and variants that are coming?
Without a doubt, Matt, we should be all concerned about the variants. And that's one of the reasons it's really important to have all the population vaccinated as quickly as possible. So the host where chances of mutations may happen is limited as possible. And I think the race to vaccination is the most important thing in the pandemic, and hopefully, we'll catch up to that, but it's just the longer it takes, the longer we continue to suffer with the pandemic. So vaccination and boosters are the most critical thing right now across the countries.
Yeah. Just thinking when we're talking about all these variants, a lot of us have gotten used to going out and having to get a test because we may have been exposed, we've got to go somewhere. Do those tests, do they help provide the medical company with data? Do those tests track the variants at all? Is that part of how we kind of see where things are going?
So generally, if you, like, let's say you go right now and you go get a test. So get a home test and you get tested. Keep in mind, a number of those tests aren't reported into the state to impact the actual state number itself. There's opportunities and there's avenues that one can report into the state or report to work, report to different entity or clinical agency, and then that get reports up to the state's data. From a sequencing perspective, the normal test that you do will not provide sequencing. And that's one of the reasons why health systems such as Hartford Healthcare, we've joined forces with labs such as Jack's Lab in order to provide that level of sequencing. So we can ensure that what we're dealing with from a therapeutic management perspective, from a detection and prevention perspective, that we're doing the right thing, addressing the right level of risk for what variant is out there. So short answer is not all tests is going to tell you what variant is, but most health system or advanced health systems have a process implemented, not just to detect, but to communicate with the state as to what's the next step should be.
When you're thinking about this and trying to decide, where the research goes, where you need to concentrate your efforts, and you're trying to figure out, you talk about particular variants being more scary, rough, or whatever. If Delta kills 1 in 100 people and Omicron kills 1 in 1,000, but the latter is more transmissible by 10 times. Is it functionally just as bad? Should we more worry about one than the other? How do you balance those considerations? Doctor?
The brains behind this is right there. So,
Matt, I think any variant which causes suffering is bad to begin with. So Omicron is just as bad as anything else. However, we are in different places in the pandemic. We've got more tools in our box right now. We've got different type of monoclonal antibodies. We've got oral medications. So what we are seeing from a healthcare system perspective, the disease which we're managing inside the hospital, we're managing largely outside the hospital right now. So that's the positive here. Where the challenge comes up with the Omicron is if Omicron is affecting individuals who are very vulnerable, they are immunocompromised, they're elderly, they've not had boosters, that's where we worry about the mortality and the concerns about it has an impact. So it is bad, but if you're well protected and if you've got the boosters and you're taking all the precautions, it's actually one of the better viruses to have compared to Delta, what we had before.
The vaccination is important, even if you still get it. It might keep you out of the hospital and avoid some of the situations we're seeing in parts of the country where beds are full and there's just nowhere to put people.
Exactly.
Absolutely. Yep.
In Hartford Healthcare, we've seen in this particular phase of pandemic, the less number of patients are requiring ICU or critical care. In the first phase, that's what was major concern, that do we have enough ICU beds? Do we have enough ventilators? Right now, that's not a discussion because those patients are requiring not so much about ventilators or ICU, they're requiring floor-based care. And the hospitals has a different capacity for that as well to manage as well.
How's it affecting long COVID? Is Omicron showing any differences with after people are sick?
A little too early to tell, Matt, at the moment because Omicron is so new, but we've seen with Delta and Alpha a fair amount of long COVID illnesses. So Hartford Healthcare is managing more than, I believe, 1,100 patients right now who have long COVID, who have got chronic symptoms and ongoing challenges with that. And we expect some of that to occur with Omicron, but I'm not entirely sure what the extent and the severity of the illness might be at that time.
So some of the original messaging was flatten the curve. We saw, the closing of restaurants and stores, people starting to work from home at that point. Over the past year, having cases be a little bit more under control, some of those measures have been lifted. Omicron has kind of tested that. Should we be thinking about shutdowns again? What do you think?
I do think that at that point, one of the things that we didn't have, or one of our biggest deficiency, was the lack of information. So Dr. Kumar also talked about the tools that we now have available. So in the process of trying to understand what this disease truly was and the impact that it can have, the measures that were put in place, I think if we look back, the question is not going to be whether or not they're the wrong measures, is whether or not we did them fast enough or we did them, enough measures were put in place. So we acted out of abundance of caution in most cases, very necessarily because there just wasn't enough information. Imagine there were people dying in critical care units that from a clinical perspective, we had no idea what to do. We've never seen anything like this before. The normal conventional therapeutics that would work on upper respiratory or respiratory diseases just wasn't working. So this was an opportunity for working very closely with, local municipalities, local government, federal government, in order to put measures in place that we believe that we could stop that transmission and flatten the curve. Now, at this point in time, a lot we do know. So we do know that, proper mitigation strategies work very well. Dr. Kumar talked about the impact of the vaccine. We continue to see the impact of vaccine, very positive impact of the vaccine. We continue to see the impact of proper masking and social distance and so forth. I don't believe at this point in time a lockdown would be beneficial for the community. I don't believe for mental health, for just normal functional community. I think we've learned enough in order to keep safe, keeping open at this time.
What Keith has talked about is really important to stress. From our healthcare system perspective, we've always believed that we got to maintain appropriate balance. So right now, because Omicron and current variant right now, we can manage differently. We can manage in at home setting. We can manage with different type of modalities right now we have. And the long-term impact it has on society with psychological, or mental health, or behavioral perspective, the balance is really important. So I like to believe that the way we have reacted with not going to lockdown at this time is appropriate. But at some point in past, when we had alpha variant, which was highly lethal, caused significant stress for healthcare system, at that time, the lockdown was the best option at the time, because we would have swung the pendulum in the other direction. So I think the thoughtfulness and the measured approach is the right way to go.
You are listening to the Municipal Voice on WNHH 103.5 FM.
Vaccines are about a year old now, and Connecticut has done a pretty good job compared to the rest of the nation with getting people their shots. 90% of people have had their first. And before the CDC revised their numbers, we were over 99% with seniors. Is herd immunity a possibility any longer?
Yes, I think herd immunity in some areas have been reached. It's just what's the true definition and expectation from herd immunity is probably what the question should be. And the challenging thing for us is the time frame that individuals got vaccinated, right? So if we look at, we talked about 99% of seniors, but let's say that was reached 6 months after. So let's say we hovered at like 60% and then we added another 39%. Now, based on what we know just from studies, not just from Pfizer, Moderna, but UK, Israel, even in the US, we know that 6 months and now challenged to 5 months as the cutoff for your Pfizer and Moderna. So if we separate those communities and we appreciate the true impact of boosters, we're probably about 60%, probably even less than that for truly vaccinated in your older population. So I think herd immunity, in the sense that when we talked about this initially, we first said 75 and 85% to really truly appreciate this. If you look at the mortality rate that existed in your elderly population before the COVID-19 vaccine, and you look at where relative mortality right now is, we've definitely appreciated a significant shift. It's vastly significant.
You can see it. It's not subtle. It
is pretty significant, right? And what we also see now is a lot of nursing homes that are talking about, or elderly community that are talking about positives. They're either asymptomatic positives or very mildly positive. So there is a shift, definitely. But I do want to stress the fact that, the booster is very important. So a lot of people that's been vaccinated that started in tier 1 to December of 21 or December of 2020, these are individuals that probably should look at now getting back up to the truly 99% is getting back up to getting a booster.
Some have argued on this line with the information that we can't consider 2 shots fully vaccinated, maybe that we should stop using the word booster. Where do you fall on that? Doctor, you have any thoughts on that one?
It's a previous question and the question you made. I think they're both interrelated to a certain extent. If I could go back to the herd immunity, and I acknowledge Keith is actually a bit more of an expert on that than I am. The herd immunity is achieved for a variant. Now we have a different variant, which is challenging our existing immunity. And the second part we've learned that, which we did not know about a year ago, is that how soon the immunity will wane from existing vaccines.
Mm.
So the virus, the bodies have actually, we've noticed that we've got a waning immunity at the moment from the vaccines, and the variants are able to bypass or attack us at this time here.
Mm-hmm.
So although we've got some amount of herd immunity, is it as effective for the current variant we're dealing with? That's a challenge we have on that part here. And for that reason, we believe that fully vaccinated is mRNA vaccines, 2 doses, 14 days apart, or 21 days apart, 14 days out after the second dose. And the booster should be considered as a fully vaccination right now, because we understand that that is probably the best protection we can provide. And short of that, we have seen individuals who have been fully vaccinated have not received a booster, getting a breakthrough infections and requiring hospitalization, and sometimes not being able to make it. Fully vaccination, our belief is that fully vaccination requires a booster as well at the moment.
Yeah. Is that something, part of what makes COVID such a problem, is that the effectiveness of the vaccines and the boosters does wear off? Because, I had smallpox and whatever vaccines when I was a child, and I haven't, I may have gotten boosters when I was younger, but I haven't gotten a booster recently. But as far as I know, I'm still vaccinated against those. So is it the mutation of COVID that does this? What's the problem there?
Well, we're still learning, Matt. The challenge we have right now is, I would imagine when the smallpox vaccine was devised the first time, we did not know how long the effect is going to be on that vaccine.
Mm-hmm.
So we're in the same phase right now. We think that the booster after the first vaccination dose, with the known variants we have right now, will be effective for a long time.
Mm-hmm.
And we may be in a situation we require a yearly or 2 yearly boosters, but not necessarily a full vaccination regime every single year. So a lot of it is unknown at the moment, and how their immunity is going to behave over the time. And what's even more unknown, what the new variants are going to come.
Mm.
So for us at the moment, is staying ahead of the course is the most important thing, and follow the guidelines. And I think after 1 year from now, we will have a slightly different conversation when we have a bit more data and understanding and what the variants' behaviors are.
We talked about how you get vaccinated, you get the booster, you have a much lower chance of severe illness. But is there an end to how many boosters we can get? Is there going to be kind of a slow loss of effectiveness as it goes on? Will there be less good results in the future? And will there be an end to vaccines, I guess?
I don't know if that's the question that we should really focus on right now. And I'll tell you why. Because it is easy to focus on that question and to lose the efficacy and impact of the current situation where the vaccine has really played a huge part, right?
Mm-hmm.
If you question whether or not, if you talk about current state, is the vaccine impactful? Yes. If within the next 6 months we need to get another booster, like everyone who's been boosted need to get another booster because this one is not effective, and we find that this booster might be the booster, some change in the actual formulary and so forth, and this might be the booster that has the most impact, then at that point we'll have that conversation. I think currently what we do see is, as Dr. Kumar says, the current booster is the most effective thing that's available right now to prevent you from hospitalization and potentially prevents from death. Can I foresee that we need a second booster? I think if you look at a study that the Israeli medical team came out with, I think it's about 2 or 3 months ago, it shows some efficacy of having actually a second booster. But there's no foresight as what happened in the next year or 2 years and so forth. So I think at this point, one of the things that we've learned from this pandemic is appreciate the data and the science that you've had and act accordingly. And as it stands right now, the booster that we have is most important. And it's almost impossible to say within the next year and a half, what's going to be the exact state and need for boosters.
Yeah, so we don't know what it's going to be a year from now, but for right now, we should all be getting that booster to keep ourselves safe.
Absolutely.
Right.
So right now, towns and cities in Connecticut are distributing N95 masks, at-home tests, but there's some areas of concern around some of these items. To start with, there's now this kind of push for individuals to use N95 instead of just the cloth. But the N95s are expensive. It costs like $1 a mask. and they aren't reusable as much. How long can you wear an N95 mask, and how important is that over the cloth or whatever?
The N95 versus cloth mask, I think N95, before we get to the N95, I think your normal blue procedural mask you see wearing in the hospital, those masks are very effective against COVID-19, a well-fitted mask, right? Mm-hmm. The problem with the cloth mask is I think most cloth masks are different from the next cloth mask, right? And I think that's the biggest challenge. So it's really hard to put some standards out there. But there's cloth masks that have certain material, multiple layers that provide a significant level of protection. So it's really hard to categorize all cloth masks. And I think when you get into N95, when you talk about N95, appreciate that what's an N95, it's not a mask, it's a respirator, and it's regulated in the healthcare system. For example, individuals have to go through medical clearance, they have to go through a fit testing process in order to wear an N95. Would an N95 be more effective generally than any other, than a mask? Yes, it would be. From a filtration perspective, it would. So that's one. Secondly, it's a more tightly snug mask. So I'm sure many of us have seen individuals around the community wearing a mask and it's not really covering nose or mouth. N95 really doesn't create that opportunity because it's such a tightly fitted mask. And I think that's the true mechanical benefit that the CDC speaks of, and the reason why some individuals have shifted to wanting an N95. A well-fitted mask in general, will do a wonderful job in preventing COVID-19 from a source control perspective and from a transmission perspective. N95, it's required in certain cases. I don't think in general, all community members, especially with general community exposure level, needs to have an N95. They just need to ensure that they have a well-fitted mask.
So the problem with the cloth is that some might be good, some might not be good, but there's no standardization to those. So it could be something that your grandma sewed for you with a couple of rubber bands. It could be medical grade. It could be, who knows, but N95 means it meets certain standards for what it's supposed to do.
Exactly. And it's a tightly fitted mask. It's very tight respirator. It's a very tight fitted respirator.
And just a curiosity, I know a lot of us have seen KN95. What's the difference there?
So K95 is a product that is used in different countries. It's equivalent to an N95. But it's their standards in different countries. Okay, so it's a different certifying body or just set of rules, but it's probably a similar product. Very similar product. They aren't necessarily reusable. How long should people use an N95 mask for? So N95 mask, generally, it's, the integrity itself is really what you use to monitor. And as long as you're able to keep that actual seal going, then it should be perfectly fine. If it's not soiled, saturated, so to speak, there's a lot of individuals that will wear it after a few hours and start getting some level of moisture buildup, and you want to change your mask at that point. And then there's some individuals that will be able to wear it, for example, in the healthcare system through an entire shift and absolutely maintain seal, integrity is perfectly fine. So it really depends. It's the key thing, what we've used to communicate is as long as the integrity is intact and you still feel comfortable with it, if you are now uncomfortable with the level of fitment that you're having, then you probably need to change it. So it's pretty basic. It's not like a ticking bomb, like, 8 hours later, I got to get rid of this. It's torn, it's dirty, it's not fitting right, it's loose. Those are the kind of obvious things that you should be looking for. Absolutely. And that can be achieved in hours for some people, and some people it can be achieved, very, very quickly. Doctor, should there be a mask mandate in the state, in the country? Where do you come on mask mandates?
I don't believe in mask mandates unless the prevalence is significant or there is a healthcare system is unable to cope up with the demand, or we are unable to provide the care to the people. However, there are some precautions we must mandate. We must continue to be on. The mask use in schools, where there's congregate setting, the kids have not been vaccinated. In areas where there's a fair amount of vulnerable populations living over there, or there is a significant risk of creating a cluster. When we talk about the mask mandate, there's a different level of mandates. Should I be allowed to go and have a food in the restaurant? Probably that's okay on that part here. But In the grocery places, when you're going for grocery shopping, currently where we are in the Connecticut with the prevalence, I suggest wearing a mask is a good thing at the moment to prevent any illness. But mask mandate when you're walking in the street or you're engaged in outdoor physical activities, probably not required at the moment. So I think there's a different level of comfort we would need to have. But I think I go back to suggesting that the way we are right now, the vaccine should be the primary focus. The booster should be the primary focus. The capacity of the healthcare system to be able to manage and support the teams should be the important focus. And Connecticut has done a pretty good job with that, and I think we should continue to stay on the course. I love Keith's input in that as well. Keith, if you have any different thoughts on that.
All right, I leave that to you, sir. That is normally. So, you know, a lot of times you ask the questions and we'll laugh about it, but we constantly have these meetings. And this morning we had a meeting and, you know, the clinical team, and these are questions we'll constantly go over, and we'll challenge ourselves with this question is, what do we think the impact would truly be? And, you know, we really have to, we don't get to celebrate a lot, but Connecticut has done a really, really good job. And I think, you know, if we stay the course with where we are right now, and appreciate individual risk assessment, appreciate the need to comply with certain things like ensuring you're wearing a mask, identify symptoms, getting tested, you know, really consider getting a booster or getting vaccinated if you haven't. I think we're in a good spot.
You know, we've all seen the kind of the rise of the at-home test because we've been all needing to test very often, and it's just more convenient. But has that thrown any kind of wrenches into the system as far as the data? You know, are people who are testing positive with their at-home test, is there somewhere where they can share that information so that it can be accounted for?
The at-home tests are effective in that it provides information to individuals to implement action. So if you do the at-home test, it shows that, you know, at least you're appreciating that you do have symptoms or you've been exposed, you've done the responsible thing, and you're finding out whether or not you're positive. So I think individuals who go out and get an at-home test, I really want to compliment or commend them on that practice itself. It does come with the other part of it is ensuring that you're acting accordingly and staying away from, you know, individuals that are high risk and so forth, and properly isolate. Now, does it really impact, can you communicate that test that is impactful with the epidemiology with the community? Absolutely. So if you do have a positive test, you should be reaching out to your primary care provider and having that communication with them saying you're positive, and if they can update that with the state itself, and that data filters in. Now, we talked about whether or not that impact variance epidemiology from a variant perspective. It doesn't, but at least it tells us that these are the community prevalence and this is what's still going on in the community.
It's still helpful to have those numbers.
Absolutely.
So with these, false positives seem kind of rare, but many people are finding out that they're positive without necessarily having the classic symptoms. You know, they can still smell, whatever. Does that mean that there's a likelihood that more than 15% of the population has had COVID by now? Like, you know, that we've been underreporting?
Oh, absolutely. I think more than 15% is, I don't know what Dr. Kumar thinks, but I would say significantly over more than 15%. And we have to look at this from the asymptomatic person. The number that we believe is about 50 to 60% of individuals that are COVID positive asymptomatic. We also have to look at, if you look at hospital data that's coming out right now, and you know, one of the things that our leadership through Dr. Kumar have tasked us to really focus on is how do we manage our incidental COVIDs? So keep in mind, everyone that comes into the hospital gets tested, right? When we look at our data right now, there's a number of people that are a significant percentage of people who are positive in the hospital, that are in the hospital for something completely different, but because they've been tested, we've picked up that they're COVID positive. So if these individuals were in the community, they would have never gotten tested, right? Yeah. So we have to the number is over 15%. We strongly believe it's over 15%. And this is the reason why it's so important for individuals to, in cases that you should, is wear a mask, for example, because you can be asymptomatic and spread the disease. And that spread might be more impactful on the person who gets it. So for example, someone with comorbidities such as advanced age, chronic lung disease, and so forth.
Yeah, so you could be feeling fine, but you go visit grandma and give it to her and she isn't fine.
Absolutely.
So it brings up some interesting questions, because I've thought about this at times recently. You know, if the being affected but not having any symptoms is more common, when should people do that test? You know, obviously you were hanging out yesterday with your friend and they tested positive, you know, go get the test. But, you know, I'm just sitting around feeling fine right now. Should I get tested just because? Or, you know, we also hear there's shortages of tests. So am I taking away from someone that might need it? How do you make that decision?
Well, you shouldn't get tested if you're feeling just fine. Let me begin with that.
Yeah.
I think it's important to think about if you're symptomatic, if you've got some symptoms you're concerned about, you should get tested at that time. I'm seeing a lot of folks actually having a testing available at the parties and just at the gatherings and things like that. I find it's a bit of a waste of testing to a certain extent in that part here. So individuals, but if you're visiting your elderly grandma who's got underlying disease and you have been in areas where you might have been exposed in public setting and things like that, I can see taking precautions at that time is the right thing to do. But otherwise, we got to be cautious about not wasting the testing as well. And it creates a fair amount of confusion by excessive testing as well.
You are listening to the Municipal Voice on WNHH 103.5 FM.
With the at-home tests, there's a lot of options now to have them covered by insurance. How does that work? Do people buy them at the regular pharmacy and then recoup the expenses? How do you get the free test through your insurance?
And my understanding is that every insurance has a different way of reimbursing and allocating the resources for that. Generally, folks will get reimbursed. Generally, obviously, they got to cross-check with their insurance provider if they're symptomatic and if they've got orders from the physicians or any healthcare providers. But otherwise, there is a risk. You run a risk of not being reimbursed as well. So cautious or clarifying with the insurance company is the best approach.
And are there any options out there to get free tests for folks that aren't covered by insurance?
Well, I think I think the governor's team is distributing a fair amount of tests across Connecticut. As you know, we've had more than 3 million tests being distributed across the state of Connecticut. The White House is starting a process, I believe, today or tomorrow in sending some of the tests for individuals as well. I think that would be one way to access it. Otherwise, I think reaching out to the healthcare providers if you're symptomatic, and folks like us are happy to assist.
Great. You mentioned the governor and the White House and stuff. Have you, as kind of leaders in the medical arena in Connecticut, have you had a lot of communication with the governor's staff, with local town leaders? Like, has there been a lot of coordination between Hartford Healthcare and the communities?
Keith?
Significant. So, you know, Matt, one of the things that we appreciated through this is how much we have of a responsibility to the community. So Hartford Healthcare, as a leader in healthcare, not just in Connecticut, but nationally, you know, very early, one of the things that we saw that was missing was the right information. So we set up a call center. I can tell you, we had to, our initial projection on the call center, we had to expand drastically very quickly because people were calling in from multiple states. I think at one point we have over 30 states that were calling into the call center getting information.
Wow.
So that was intricate, important. The other thing that we saw that was very, very important, very necessary, and this is knowledge that we gained from communicating with community partners, including, you know, the mayor's office, multiple mayor's office, and the governor, is a need for testing. So we started the multiple drive-through mega testing sites. And then right after, we appreciated the advancement in science, and we needed to start to communicate the efficacy, the importance, impact that the vaccine might have before the vaccine came out. And Hartford Healthcare, you know, working with our community members, was one of the first health systems to deliver the vaccine in the state of Connecticut, but at a magnitude that had such an impact, a profound impact in Connecticut. In the same time, communicating with specific leaders as to what it is that is needed in these communities to ensure that we're getting compliance. So does it mean door-to-door service? Does it mean delivering vaccines to at home for home care patients that are receiving home care? And we, you know, was constant communication with our community leaders. And through that, we advanced with our therapeutics, the monoclonal antibodies, and now we have, other therapeutics such as Paxlovid, which was a pill. Again, communicating with our community members, it is, to us at this point, is probably, and the relationships that we've developed is probably one of the single most important advancement for this health system and the community throughout this COVID-19 pandemic. So very, very, very important. We can't stress, there's many things that we've achieved, but as I would say, the biggest thing that we've achieved, we've created more infection preventionists in the community through our communication. We've created more partnerships and partners within the community. And as we look at the disparities that exist within our communities, we've been able to create channels to open communications to hopefully address these disparities, which we now know has have had a profound impact on the impact that COVID has managed to have within these communities. So I think many things will change, and a lot is coming from just the communication that we've created. We've expanded, not just created, but expanded with community leaders across the state.
Yeah. So do you think that all this work that's been going on with the communities, does this leave us in a better position for, unfortunately, the next thing that comes along?
Absolutely. And I know Dr. Kumar is going to expand on that, but we are, at this point in time, Connecticut is in a better space from a healthcare future perspective, based on not just the collaboration with Hartford Healthcare, but I know other health systems are doing a good job as well to try to build on that relationship and address certain disparities in certain areas of healthcare in Connecticut.
Excellent.
And if I could just make a couple of comments. So in the first phase of the pandemic, we focused on how do we expand our resources as best we can to provide the information or reduce the misinformation we had in the communities existing at the time here. Initially, what Keith was referring, we set up a call center. Within 24 hours, we had a demand which was increasing, about 3,000 plus calls coming in 24 hours. So we had almost 10 physicians or nursing individuals sitting and providing information of what we knew and how we were managing at the time. Fast forward today, right now our focus has been how do we actually manage the pandemic, which is largely outpatient based, right? Not in the hospitals so much. So we've got our monoclonal antibody clinic set up. We've got a Paxlovid clinic set up. We've got behavioral health, virtual health system set up. Our medical group is providing a evening and weekend hour access to physicians to seek care at this time. So our system continues to react to what is needed at the moment here right now. We are opening multiple trailers for testing now in state of Connecticut across throughout this Connecticut right now. So our system is designed to serve what is needed. Our neighborhood health is supporting our underserved population. Keith Grant has been a leader in reaching out to different type of communities in underserved areas to make sure that we're providing information, providing vaccines, boosters, and testing. So the system has reacted to the need of the community, and we're going to continue to stay ahead of that. And I do say that with largely most healthcare system in the state of Connecticut have reacted appropriately to meet the needs of the community as well.
Excellent. And I think kind of finally, is there an end to all this? You know, we've heard from some of the Biden administration, arguing that people should be prepared to just kind of live with this for the long haul. Are we ever going to get back to normal? Is the new normal just ongoing conversations about the latest, greatest mask and how you work from home? Where do you see the future going with this?
I don't think we're going to go back to normal. I think we're going to redefine normal. And Jeff Flax, our president and CEO, talks about better than normal. And I agree with that. I think we've learned enough to be a better health system, to be a better community. We've learned enough to appreciate the importance of collaborative efforts. We've learned enough to appreciate the impact of a disease on communities if we don't figure out how to get that community access to healthcare quicker, right? So I think we're going to be much better than normal. From an epidemiology perspective, I think this disease, and the numbers show that this disease, this virus, is in a space, a pivotal space at this point, wherein within the next few weeks, we'll be able to tell, I shouldn't say we'll be able to tell, but we will know more information in that, what's going to happen in the next 6 months. We believe that the primary peak has been reached in most communities, and we start seeing either a decrease in the rate of increase, or we're seeing a decrease in the overall numbers itself in most communities. So we'll continue to watch that. Again, some things can complicate this, such as individuals deciding to change social habits, to individuals deciding boosters aren't as important again. And, obviously, if a new variant comes out and kind of add some level of complexity to it. But I think where we are this year versus where we were last year, we're in a better place. And I think we are improving much rapidly than we did last year this time. So I think next year or the next few months, we should be in an even much better place.
Well, that's good to hear. Doctor, is there anything that you wish people knew about COVID that maybe we didn't cover? Do you have any advice for those listening at home?
From our experience in clinical setting, we have seen individuals who are not vaccinated, not boosted, are still dying with a high proportion at the moment, requiring a critical care, requiring ventilation, and going through tremendous amount of suffering at this time here. So I would go back and stress those individuals who are still not sure about the vaccines and boosters, do reach out, ask the right question, get some information. Our goal is to protect, reduce suffering and mortality, and create a wellness. And I'm hoping the individuals who are listening today, who are still thinking about the vaccine, look at the numbers and make the right decision.
We'd like to thank our guests, Dr. Ajay Kumar and Keith Grant of Hartford Healthcare. I'd like to thank our premier sponsors, Digital Back Office Palo Alto Networks, who you can check out at digitalbackoffice.com and paloaltonetworks.com. The Municipal Voice is a co-production by CCM and WNHH 103.5 FM. Kevin Maloney is our executive producer, Christopher Gilson is our producer, Harry Draws is on the boards, and I'm Matt Ford, your host. Be sure to check out our Facebook page and give us a like, and watch out for our CCM chat series on our YouTube page.